Good evening.
Good evening, madam. Nice to see you.
Good evening.
Same here.
Sir, very good evening, Dr. Rajiv sir. Very good evening.
हाँ जी डॉक्टर गीतांजलि। नहीं अभी हमें होस्ट बनाया ही नहीं है ना।
Good evening, all.
Good
And
evening,
we're
Dr.
live.
Naveen.
Good to go.
Good evening.
Namaskar.
Good
madam.
evening,
Good
madam.
evening.
Good
Good
evening,
evening.
Good evening. Good evening Naveen sir.
Sir, very good evening,
evening.
Dr. Rajiv sir. Very good
Namaskar.
evening.
Good evening, all.
Good evening Dr. Naveen.
Namaskar, sir. Good evening to all. Good evening. Good evening.
नहीं अभी हमें होस्ट बनाया ही नहीं है ना।
Good evening, all.
Good
And
evening,
we're
Dr.
live.
Naveen.
Good to go.
Good evening.
Namaskar.
Good
madam.
evening, madam.
Good evening. Good evening.
Good evening. Good evening
Sir,
Naveen.
very good evening to everybody. With your due permission, President Dr. Naveen Malhotra sir, do we begin our session, sir?
Good evening, sir.
Should we begin, Naveen sir?
Please start.
Dr. Amit Kohli, please, over to you.
Yeah. Thank you Dr. Vishal. Dr. Vishal, if you can make myself, Dr. Lalit and Dr. Gitanjali the co-hosts
Sure.
as well.
Just give me a minute, please.
Yeah, sure. Thank you.
Hello, Naveen ji.
Namaskar. Namaskar. ji. Dr. Amit, good to go.
Thank you, sir. Good evening, President RSACP, our own Dr. Naveen Malhotra, sir, and Secretary RSACP, Dr. Vishal, and Honorary Treasurer RSACP, Dr. Sunil Sethi, sir, and all the other governing council members. It's a proud privilege on this evening that RSACP Delhi is hosting today's webinar. Sir, with your blessings, this webinar was supposed to be a few months before, but due to some unavoidable reasons, we couldn't host it, right? And because everything is destined, I said, because this is an auspicious day today, and it was destined that we all will be meeting on the auspicious day. That is, some part of the country, Sankranti is being celebrated today, right? This is there. So on this particular auspicious day, we all have been meeting together. It's thank you so much, sir, for giving all of us an opportunity to interact with each other this evening, right? I just want to share one thing that today's moderator has to be Dr. Avijit Kumar as per the flyer, but there was some unfortunate thing happening last few days with him. Suddenly his father became unconscious, suffered a cardiac arrest, and we're very proud that he was at home and he gave cycles of chest compressions to his dad, right, and rushed him to AIMS, right, and he's improving, right? He's improving and came back home just yesterday. But he helped me out throughout in this particular, even in tough times, collecting CV slides from our today's speakers and chairpersons as well as the panelists, and compiled slides reached me well in time today morning itself. So that's the dedication he has shown, but he is unable to join us today because he has to take care of his dad. So without taking much time, so I'll be moderating as well as coordinating today's session on his behalf as well. So let me introduce, and thank you so much, sir. I'll invite President RSACP Naveen Malhotra, sir, for the welcome address, please.
Good evening, all, and wish you all a very happy Makar Sankrant, Pongal, and it is an auspicious day. And doing this webinar by Delhi branch is an excellent move. Whatever happens, happens for good. And the topic which you have chosen, pre-anesthetic checkup, and a very, very respected Dr. Jayashri Sood, Madam, Dr. Monisha Agarwal, Dr. Rashmi Ramchandran, very dear Dr. Rajiv Gupta, Dr. Gitanjali, and Dr. Lalit Gupta will be will be the webinar faculty. So I'm very sure that the audience will have a very good time listening to these stalwarts from the capital of India.
Thank you
I
so much,
extend,
Naveen
I
sir.
extend a cordial invitation to all of you to attend the annual national conference on 10th, 11th, and 12th April at Indore uh, at the Brilliant Convention Center. We've got more than 10 workshops on Sunday, 12th of April. And the whole team is working, Indore team is working day and night to make the conference successful. I welcome our patron, Dr. Tej K. Kaul, sir. And please bless us, sir. Dr. Tej K. Kaul, sir, please.
Happy Makar Sankranti to everyone. A notable event like this webinar having being started on such an auspicious day by the Delhi branch of RSA is very satisfying and very pleasing. I wish the topic selected is very relevant, very important, right from the beginner in anesthesiology to the most expert in anesthesiology. It is a topic which needs to be revised time and again whenever the chance arises. And it is a very auspicious beginning on such an auspicious day. I wish the speakers, the moderators, the chairpersons, Dr. Naveen, Dr. Vishal, Dr. Sethi, everyone, and the best wishes and all that is best for RSSA. God bless you. God bless you all. Thank you.
Thank you, sir. Over to you, Amit.
Thank you so much, Kaul sir. Your good wishes and blessings are always and always precious to us. And this is there. Now I'll invite our Honorary Secretary, RSA National, Dr. Vishal Singla, to please speak a few words.
Very good evening to everyone, and my regards to our patron, Dr. Tej K. Kaul sir, President RSA, Dr. Naveen sir, Treasurer, Dr. Sunil Sethi sir, and all the delegates here on the board. And my special warm regards to Dr. Jayashree Sood, madam. We are also lucky to have. Also, we are having the ISA president, honorary secretary ISA, as well as treasurer ISA with us. So that makes this webinar more important. Thank you very much, and congratulations to Team Delhi for crafting this such a wonderful webinar. Hope we would be enjoying the academics, and this is one of the basics in anesthesia PSC. Thank you very much. Over to you, Dr. Amit.
And congratulations to Dr. Amit, the National Governing Council member of Research Society of Anesthesiology, for organizing this webinar, and our prayers for speedy recovery of Abhijit's dad. And we are happy to share with you that this Sunday we are having a RSA-sponsored CME at AIMS Bhubaneswar on Sunday, 18th January. Best
Thank you
of luck
so
to all.
much. Thank you so much, sir, for your blessings always upon us. And I'll convey your good wishes to Abhijit as well. Right, this is there, and your dynamicity, lot of programs since last years we have been seeing under the banner of RSA National. All kudos to you, sir. Without taking much time, I'll be wanting to introduce my first speaker. Are my slides visible?
Yes.
Yes, sir.
Yes,
Thank
sir.
you. Thank you. So as Kaul sir has already mentioned that yes, pre-anesthetic checkup PAC is an area where the first interaction of the patient occurs with the anesthesiologist. Right, this is there we have a rapport building. There we have, it's kind of a boarding pass which we give to our patient to fly high. Right, this is there. So it's my honor and privilege to invite my dear friend, as well as a co-faculty in the Department of Anesthesiology at Maulana Azad Medical College, Dr. Lalit Gupta. He is professor of anesthesiology. His areas of interest are pain medicine, difficult airway, remote anesthesia, as well as intensive care medicine. He is also the editor-in-chief of Indian Journal of Clinical Anesthesia, and a very good academician and a national awardee as well. So I welcome you, Dr. Lalit, and he'll be speaking on risk stratification in pre-anesthetic checkup.
Thank you, Dr. Amit. Thank you, the honorary faculty of RSCP Con. Uh, yes, so I will be sharing my presentation for today. Okay, I hope my slides are visible.
Yes.
Yes, very much.
Yes, it
Okay.
was very much visible.
Thank you, everyone. A very warm evening to everyone. The topic I will be taking for the next 10 minutes is the risk stratification in pre-anesthetic checkup. And whatever I am telling you is not from the clinical intuition, it's up to the validated evidence-based model. So I am Professor Dr. Lalit Gupta in my faculty of Maulana Azad Medical College, Department of Anesthesia. So moving to this final presentation. So why have you ever thought of why we need a risk stratification in the PSC? Because it is important for the health of the patient as well as on the surgery, what we are going. There is a patient reserve and surgical stress, and we have to maintain them with equilibrium. So our primary goals are optimization, resource planning in the form of ICU, ventilator, and informed consent in case of morbidity risk patient. And in the recent time, there is a shift from optimization of surgery versus cleared. So now we are not clearing the patient, we are optimizing for the surgery. Uh, Importance lies in the fact that it reduces the complications if the stratification is done by 20 to 40%, improve the mortality rate by 15 to 25%, informed consent, and in a meaningful discussion with the patient, 85% of the patient report improved satisfaction when the risks are clearly communicated to them. And moreover, the allocation of the resources like ICU beds, monitoring equipments, personals, it is decreased by 12 to 14% if the efficient resource utilization is done. So in all, if are calculated, there is a 70 to 80% reduction in all the equipments, the mortality, and whatever the things we are using the resource utilization. The component of perioperative risks include both, as we discussed in our long cases, the patient factor, the surgical factor, anesthetic factor, and the institutional factor. Regarding age, frailty, comorbidities, functional status to the urgency of the surgery, the invasiveness, the blood loss expected, the surgeries versus GA versus regional, always debatable, the airway securing, and finally the availability of the invasive institutional like the cath labs, the ICU availability. What I'm telling you is all that has been already published. So this is the algorithm that I have always teach to my students that a risk stratification starts from the history taking. From history, everyone goes to the ASA grading, and from there, now you know your patients. So you know it can be the normal patients like ASA 1 or 2. The cardiac factors are involved, the pulmonary, or there are the other factors. So if the cardiac factors are there, you will go for the spare, like these are the revised cardiac risk index and the MATS. In the pulmonary, they have the stop bank scores, the RSACP scores, and the ISA guidelines that we follow for such patients. And finally, our main aim is to plan and optimize. Take the informed consent, take the patient in confidence, and then do the surgeries. So coming to the ASA stratification, why it is important for the our risk? Because if you see this graph from 0.1% in ASA1, which is actually may happen, the 60% mortality is there in the ASA5 patient. And we know we are usually doing the 3 and 4 patients, which are really 3.5 to 18.5%. Data is actual already published and it shows that why the risk stratification is important. But it has some limitations. You know, it's an inter-observer variability and there is a lack of surgical contact. For example, ASA3 cataract versus ASA3 Rippers processor both have the different mortalities and different equipment utilization. Similarly, prediction power like for the mortality, cardiac complication may differ in each of the patient. And we may need the objective scores to supplement the ASA scoring. So our ASA is not complete. It requires some supplementation. We need the mats of the patient in the form of like the patient is having the self-eating MALF only. It's a mat of 1 to the 4 that is able to climb the two flight of stairs at the speed of 4 miles per hour. To the more than 10 that shows the strenuous sports. So the critical cutoff are less than 4, which shows the high risk of the patient. But then we know the patient is cardiac, we have to follow the several guidelines, which has the step-wise ladder pattern. Like in the emergency, we have to proceed despite the fact the patient is how much is optimized. But if we delay and treat, the cardiac complications may be compromised. We have to assess the risk by the revised cardiac risk index and SQIP index. Then less than 1%, always proceed. More than 1%, please assess the function capacity for the further equipment. The RCRI index, which has the 6 independent predictors of major cardiac complications, and it has a different score. From the high risk surgery to ischemic heart disease to the heart failure, strokes, DM, and the serum creatinine level. So if there is no risk factor, it is very good up to the 0.4% the mortality, and if there is a higher risk factor, up to the 9% can be their mortality. But at the present, there are some better predictors like the NSQI, which is the National Surgical Quality Improvement Program system, which includes the 21 variables and some codes. With the surgical risk calculator and American College of Surgeons, it is the combined device by them for their patient. It includes all the cardiac pneumonia, the SSI, the thromboembolism, death, and rehabilitation. Every code is there. Advantage is that the specific risk, procedure-related risk can be found out, and it is the more predictable than the CRCRA index. Now, there is one more Indian Gupta's Mika model, which includes the age, creatinine, ASA, functional status, and procedure type. And it is also very predictive of the patients. Cardiac biomarker, yes, we see for BNP and troponin in the cardiac patient, and we normal, not routinely pre-op unless the ischemia is suspected. Significance is that elevated pre-op, it predicts the 30 days mortality. Suspected and stabilized heart failure, age is more than 6, undergoing high risk surgery is one of the few indications that we usually use for them. Now coming to the RSACP score, that is the assessed respiratory risk in surgical patient in Catalonia. Catalonia actually was a place where all these respiratory guidelines were made in the Europe, but it's a very good score. It includes it predicts the post-op pulmonary complications, involve the 7 variables: age, saturation less than 96, respiratory infection, history with less than 1 month, anemia, upper abdominal incision, surgery of more than 2 hours, and the emergency nature of the surgery. And if the score comes to be combined more than 45, it's a very high risk for the patient from the pulmonary point of view. Then we have the stop bank score for the obese patient and the pulmonary complication, which include the snoring, tired, observed, pressure, BMI, age, neck, and gender. And if the score is more than 3, it means there is a high risk for the surgery. Similarly, if the patient is having the renal complication, please see for the EGFR. If it is less than 60, the patient is on the diabetic, on the ACE inhibitors or the ARB inhibitors. Surgical risks include the contrast, hypotension, cross clamps, and creatinine is more than 2. It means the patient may require fluid optimization and nephrotoxin avoidance during the surgery. Hepatic risk, we usually see the child classification and the MALD, that is the modified score, which include class A, B, and C, which have the different mortality. And similarly, in the MELD score, we take the bilirubin, INR, and creatinine, where if it is less than 10, the mortality is low. More than 50, the mortality is very high. And the frailty. Nowadays, everyone now thinks of the frailty. Frailty is very important because it has a scale of 1 to 9, means from fit to the terminally ill patient. There is a separate score for that. And one of the score is the eyeball testing, where the gait is followed. And if it is more than 15 seconds stuck in the gait, it means the V grip is there and the mortality is high. And it predicts not only the mortality, but also the discharge from the hospital or the nursing home. Now, the patient, once we have seen what type of risk is there, the next we move to the nutritional. Nutrition involves the hypovolemia. If it is less than 3.5, means that predicts the poor surgical site infections. They are very much high. Poor healing, anastomotic leaks are there. So please try to build the albumin more than 3.5. Assessment must tool, that is the must tool, multi-nutrition universal screening tool is another tool used for such high-risk patient like Whipple's procedure or the midline abdominal surgery. If the score is more than 1, please load the patient, build up the protein for at least 7 to 14 days before the surgery. Thromboembolic risk, yes, it may be score there, and their score we use the capillary risk score. And the patient like the age, the cancer surgeries, when the patient has the previous history of DVTs or the patient is the bedridden. In such cases, we usually choose the capillary risk score. And if 0 to low is a very high, there is low risk of the surgery. And if it is 5, more than 5, please start the low molecular weight heparin or if you require the other filters. Bleeding risk is there if there is a history of or It is more important than the lab reading actually. If the patient says I have the bleeding gums and bruising, please go through that. Coagulation profile only if indicated. And please remember the stop dates of their drugs, like clopidogrel has to be stopped 5 to 7 days. The direct anticoagulants 24 to 48 hours is because they are the renal dependent. And warfarin is there. Please bridge it with the low molecular weight heparin if the patient is of high risk. Then come our the favorite airway because we are the airway masters. We have to manage. They are the different score, and also all of you know. So, but few of them you follows the lemon score, the Mons or the Machoka scores for the ICU patient. And each score has a different evaluation from mouth opening to a thyromental difference, the Malam patti, neck movements, ability to prognathia, weight, and history of the difficult intubation. Different scores are given. So whatever you are follow, the Malam patti has to be followed, and there is systemic way you are seeing the airway of the patient. Now, since we have seen most of the things, now we come to the why. What are the differences between the American Society of Anesthetists guidelines, which is USA, given to the ISA, which we are following, and two these are the 2022 guidelines. Uh, ASA says clinical judgment is more important. No routine testing is important. But ISA categorized the surgery in the minor, intermediate, and major as along with the ASA classes. ECG is not routinely recommended by the ASA only if the cardiac history or symptoms are exist. But ISA says please do in all the ASA 1 and 2 patient, even if they are 1 and 2, but the age is more than 45, and in the major patient in all the patients. Chest X-ray really indicated only for the acute or cardiopulmonary signs, but ISA says recommended for the age more than 50 and not for the minor. However, maybe the ASA 1 and 2, but if they are more than 50, please go through them. Lab validity, there is no strict cutoff in ASA, generally 6 months, but ISA says that 2 months for the biochemistry and hemoglobins and hemograms, 1 year for ECG and chest X-ray if the previous for the asymptomatic. Coagulation profile like PTINR, BTCT, only if the history of bleeding or liver disease there in ASA. Same, not routinely done in the ISA, recommended only for the neuroaxial blocks in the some high risk setting. Blood glucose, ASA says that diabetes or the other suggestive symptoms, but ISA says not recommended if no history of diabetes. However, few guidelines have now surged which says that all the patient of age more than 18 years should be done because diabetes is one of the most covered comorbidity which is usually seen on the day of the surgery when the blood sugar is done. So it is better if available, please do it. So what actually they say that CBC renal LFT validities of 2 months as per the ISA. ECG X-ray can be 1 year, and blood sugar on the day of the surgery if required, because the validity lies only for the 24 days on the day of surgery. Fasting guidelines should be followed because uh, we always now 2468 rules is always there, and sip till sand rule, that is the clear fluids from where you can read the newspaper, should be allowed up to the 2 years. Now, one more concept is added in the risk stratification, that is the prehabilitation, which means wait time for the surgery is used to optimize the patient to decrease the mortality and morbidity. It has the three pillars. One is the exercise to improve the meds, nutrition, as I told earlier, 7 to 10 days prior for protein and iron, and psychology. When you interact with the patient and teach them, there is always anxiety reduction. And please, if the patient is smoking, allow him to stop 4 weeks for pulmonary rehabilitation. Risk communication, I told you, must be clearly communicated. Please, documentation is equally important for the risk stratification. High risk consent, post-op ICU requirement, specific risk like stroke, death, or ventilator requirement should be clearly told to the patient. Day of surgery, kindly re-evaluate whatever written in the PSC. It's a snapshot of the status can change anytime, remember. So it's your guideline. Check the NPO status, morning medicine taken or not, any new like upper respiratory tract infection is there, go or no go decision. That all is decided on your PSC snapshot. Please always follow the surgical safety checklist. And I have made it comparative table of the risk stratification tool where you say that the surgeon's QIP index, which has the highest uh, correlation with the mortality risk. While the POSUM and stop bank scores, the stop bank score and the ARC card and RCRI have the low predictability, and frailty score has the moderate complexity and correlated well with the mortality and morbidity of the patient. So please keep in mind which score you are following and the complexity of the score and its correlation with the morbidity. To conclude my lecture, I would say scoring systems are always there, just need always go for the objectives over the subjective ones because scoring systems gives you the direct correlation. Maths is the key predictor. Functional capacity matters for any type of surgery. Follow the ISA guidelines. They are the evidence-based testing and they are from the multi-meta analysis. And please, certification is equal to safety. Remember, improved patient outcomes is the key. Thank you very much.
Thank you so much, Dr. Lalit, for such a comprehensive talk. Right, I think the audience and the delegates today gets benefited with it. We'll
Thank
take
you,
the
sir.
questions at the end of the webinar. I request all the delegates to please put down any question in their mind in the chat box, and we'll take up in the end. Thank you
Thank
so
you.
much once again, Dr. Lalit.
Thank you,
Now
sir.
I take privilege. Now it's a time for after a comprehensive talk about the risk stratification, it's now the time for panel discussion. I take a privilege to invite another dear friend of mine, Dr. Gitanjali T. Chilkoti. Dr. Gitanjali Chilkoti is also the governing council member of ISA Delhi branch from East Zone. She is a director professor in Department of Anesthesiology and Critical Care at UCMS and GTB Hospital. Her areas of interest are obstetric and pediatric anesthesia, airway, and resuscitation. She has also been awarded with various state awards, as well as she has almost 100 publications to her credit. Over to you, Dr. Gitanjali.
Thank you so much, Dr. Ahmed. I'll share the slide.
I request you to please invite your panelists, and then I'll stop my screen so that you can, go ahead with the panel discussion.
Is my screen visible?
Yeah.
Is it visible now? Is the screen visible, Dr. Ahmed?
Yeah, it's visible. Just make it a full size.
Yeah, I'll I have made it full screen. Okay, good evening, everyone. I welcome you all to today's panel discussion on pre-anesthetic setup. The pre-anesthetic setup, we all know, is a critical step in perioperative care.
Dr. Gitanjali,
It helps us
is it a
to
presenter's
identify
view?
No, it's a full screen.
Okay.
Just a minute.
Slideshow?
No, it's a full screen. It's a full screen.
Go ahead with the slideshow.
I've done it. Is it not showing the full screen?
Just try to make does a slideshow? Yes, above.
I'll change the layout.
Yeah, just click the slideshow at the top. Yeah, the slideshow bar.
Ma'am, it is mentioned there from current slide. Go left, ma'am. Go left. Go left. More left. More left. Down. 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 Yes. Yes, please.
Okay. Is that full screen now?
Yes, ma'am.
Yeah, now it's okay.
Thank you so much.
Yeah.
Okay, good evening, everyone. I welcome you all to the today's panel discussion on pre-anesthetic setup, do's and don'ts. The pre-anesthetic setup, we all know, is a critical step in the perioperative care, and it helps us to identify the comorbidities, anticipate anesthetic challenges, optimize patients, and prevent complications. And sometimes it can save lives as well, as small details during PSC can make a big difference. And we are privileged today to have with us four senior anesthesiologists who will share their experience, practical tips, and lessons learned from their years of clinical experience. And we have with us Dr. Jalshi Sood ma'am, Ma'am is an emeritus consultant and advisor. She doesn't lead any interactions. She's the vice chairperson of Board of Management, members of Gangaram Hospital. Ma'am has several accolades and honors and achievements to her credit, and we welcome you, ma'am. Our next panelist is Dr. Manisha Agarwal.
Gitanjali ma'am, your voice is little not clear, ma'am. Can you please bring your microphone a little close to your face, ma'am?
It's close. Is it?
Okay. Can you be a bit more loud, please?
Okay. So our next panelist is Dr. Manisha Agarwal, ma'am. Is it better now?
Yes, ma'am, definitely.
Okay. So our next moderator is Dr. Manisha Agarwal, ma'am. Ma'am is Director Professor and Dean at Anna Azad Medical College. Ma'am's area of interest are fibroscopy and difficult airway management, BLS, ACLS, pediatric anesthesia for pediatric surgery, teaching and training, and medical oxygen infrastructure, logistics and management. Ma'am also has several achievements and accolades and honors to her credit. We welcome you, ma'am. Our third panelist is Dr. Rajiv Gupta, sir. Sir is the Honorary Secretary ISA National and is also a senior consultant and head Department of Anesthesia at Interventional Pain Management at Maharaja Agrasen Hospital. Sir's area of interest are difficult airway, interventional pain management, medical, legal and ethics. Sir has been the past governing council member ISA National, past secretary ISA Delhi and past president IA. Our fourth panelist is Dr. Lakshmi Ramchandran, ma'am. Ma'am is professor in the Department of Anesthesiology and Medicine at AIIMS Delhi. Ma'am is the professor in charge, skills and stimulation at AIIMS Delhi. Ma'am also has several achievements and accolades to her credit. We welcome you, ma'am. So to start with our panel discussion, it is very important for us to know what are the primary goals and expected outcomes of a comprehensive anesthetic checkup. I would request Dr. Jashree Sood, ma'am, to kindly.
Thank you, Gitanjali. And thank you very much for inviting me here for this panel discussion. Can you hear me, Gitanjali?
Yes, ma'am, you're audible.
Okay. So, as you asked about the primary goals and expected outcomes of a comprehensive pre-anesthetic checkup, Dr. Lalit has given us a very nice overview of all the risk stratification. And we must all know that we as anesthesiologists always are interested only in patient safety. Patient safety, a good outcome for whatever procedure he or she has done. So definitely the goals that we do is that patient safety should be there and complications should not be there. And when we do a good PSC, a comprehensive PSC, we then, after listening to the history and the other investigations, etc., we come to we plan the anesthetic procedure, whatever we are going to do for that case. So that is the reason the goal is very important, that we see the patient, do the examinations, see the investigations, and then plan the anesthesia. So also in the outcomes, of course, we want safety, we want reduced mortality, we want reduced morbidity, we want shorter hospital stay so that the patient can go home as early as possible. This will, of course, reduce the resources in the hospital. The financial resources will be much less.
Ma'am, is the screen visible?
No, I can't see,
No.
Gitanjali.
No, not yet.
Are you
Not able
showing
to.
something?
I think just a minute, ma'am. Just a minute.
Cannot see anything on the screen.
Yeah. Yes, ma'am, I'll just do it. Ma'am, I'll stop share and I'll reshare it.
Okay.
Is it visible now?
Yeah, we can see. We can see.
Thank you so much, ma'am. Now, a very common question which is often asked during PSC is that how soon before surgery should a PSC be ideally done? And because we all know that it determines the outcome. So the question is that what is the ideal timing of a PSC in relation to elective surgery? And how does timing influences the perioperative outcome? When we go on to the evidence, the ASA practice management guidelines clearly says that the PSC should must begin up to 30 days before elective surgery, but must be reviewed and updated and completed within 48 hours before surgery. And high-risk patients and major surgeries, the PSC can always be done a day before. However, it is recommended sufficiently in advance of elective surgery in dose optimization, with most Indian practicing aligning with ASA principles as well. So, as far as the ISA is concerned, there is no explicit time-bound guidelines which have been issued. We can all see here that the core component of a comprehensive preoperative assessment, it is here shown as an integrated cyclic process where the elements are a good history taking, a thorough physical examination, investigation and risk stratification. And as we can all see here that all these elements, they are interdependent and they are iterative, together enabling the optimization and shared decision making and thus safer anesthetic planning for the patient. So coming on to each one by one, my next question is that what are the key do's and don'ts in history taking during a pre-anesthetic evaluation?
Uh,
I would request Dr. Manisha ma'am to kindly address
yes,
this one.
thank you, Dr. Gitanjali. As we all know that focus history is one of the most important initial steps of any a good pre-anesthetic checkup. So first I'll talk about the do's. Uh, History taking should start with questions relating to the present illness or sign symptoms of the patient. So one should be inquiring about questions related to all the systems, broadly respiratory, cardiac, CNS, etc. So I would start by taking history for any cold, cough, breathlessness, palpitations, uh, tiredness, and to assess the functional capacity, ability to climb 2 flight of stairs, then convulsions, unconsciousness, any episodes, bleeding disorders, history suggestive of any bleeding disorders, jaundice. Thereafter, you can take history pertaining to specific comorbidities, important comorbidities like hypertension, ischemic heart disease, diabetes, tuberculosis. Then one should also, if your patient overtly looks morbidly obese, you can also ask history pertaining to OSA. Then another important aspect of history taking is any previous exposure to anesthesia or any other surgical procedure that the patient has undergone under anesthesia. Then specific questions related to anesthesia, for example, did any was intubation difficult? Did the patient have was diagnosed to have a difficult airway or difficulty in putting regional anesthetic? Was there any problem intraoperatively? For example, awareness, questions pertaining to awareness, or post-op period, excessive nausea, vomiting, or pain. Then we come to certain alerts. Is the patient allergic to any particular substance or any particular drug? Then drug intake history, which maybe patient may be taking drugs related to any of his comorbid illnesses, for example, hypertension, diabetes, or very important, these days it's very common to have, taking any herbal drugs for various purposes or bodybuilding substances. One should always take note of all these drugs. Then the fasting status of the patient, more relevant if you are taking history for an emergent surgery. Then all these and also certain points related to the surgical procedure itself. As Dr. Lalit mentioned in his presentation, for example, a patient undergoing cataract surgery versus a patient presenting for a Whipple surgery. So certain points in history are related to the surgical procedure itself. So these are the do's of taking a good history, and then you correlate your history with the systemic examination of the patient in taking into account the proposed surgical procedure. And coming to the don'ts, what you should not do, your questions in the history should be specific. They should not be vague. Because vague questions, you will get vague answers. You are wasting time of the patient as well as your own time. So questions like this, how are you feeling today? Do you have any problem? They are non-specific questions. Your questions should be very specific. Then one should not rely solely on the old records that the patient presents. Good history may, reveal many risks which are missed on papers. Then you must take history pertaining to any recent onset symptoms, for example, recent URI, etc. And we should not ignore these, and we should take good cognizance of any recent signs, symptoms, or the medicines which patient might have started for that. These are the few do's and don'ts of a good history in the PAC checkup.
Thank you so much, ma'am. Thank you, ma'am, for completing the whole list of do's and don'ts while history taking because it's an integral part of the aesthetic checkup. Now, after history taking, we all know physical examination again is very important. We must know what are the essential do's and don'ts of physical examination during PAC and what are the components which should never be missed that includes the area assessment. I would request Dr. Rashmi ma'am to kindly answer this one.
Thank you, Gitanjali, and thank you, team RSACP for inviting me here. So, moving on with the examination for pre-anesthesia checkup, I would suggest that if we do the PAC in a very structured manner, we do the physical examination in a structured manner. So start with the general examination first. Don't take anything lightly. I think I should start with the don'ts first. Don't take any of the examination lightly. Even general appearance of the patient shouldn't be taken lightly, especially when they are being posted for major surgeries. Then after the general physical examination, never miss cardiovascular and respiratory examination. Always auscultate your patients. Always go in a structured manner, like in respiration, always auscultate first and then see if any adventitious sounds are there. In CVS examination, auscultate for murmurs, auscultate for the cardiac sounds. And once these systemic examinations are done, then never miss the surgical related examination. So if it's for an abdominal surgery, always look at the abdomen. If it's a major tumor surgery, look if the the tumor is so large that the abdomen is distended. Do we need to take aspiration give aspiration prophylaxis to the patient? So these things should be done in a very structured manner. And when you're doing as an anesthetist, the three most important things not to miss is the airway, the IV access, and the spine. So in spine, also add any examination that is needed for regional anesthesia. If you've planned a regional anesthesia for the patient, look at the site where you want to put your needle. So all these things should never be missed. And a comprehensive airway examination, regional anesthesia procedural examination has already been covered by Dr. Lalit. Thank you, Gitanjali. Back to you.
Thank you, ma'am. Ma'am, can you please tell us something about the area assessment in pediatric patients?
So pediatric patients specifically, yes, they are going to be a little difficult, but a general look of the patient himself or herself, you would know that the airway is going to be easy or difficult. Neonates, infants, chubby infants, we already know that the airway is going to be difficult. Then surgical related complications like airway tumors or uh, some facial tumors are going to be difficult, we all know. What is not to be missed is loose teeth. Typically, children after 5 years start asking for whether they have loose teeth or not. So all these things are important when you look at the children, but a formal physical airway examination in a structured manner, of course, is a little difficult in pediatric age group.
And there could be role of some physicians like Wilson physicians because a lot of time in PAC what the residents usually do is they will just check an MPG and
Sorry, Gitanjali, you're not clear. I didn't get your question.
Okay, Dr. Rashmi. Ma'am, am I audible now?
Ha.
Yeah. Ma'am, I'm saying that often in PAC, residents get away with the MPG grade environmental distress. So I think as Dr. Lalit also has just highlighted the fact that some kind of indices or some abbreviations like Lemon and Mons or Wilson indices can also be integrated while doing the PSC. I mean, that should rather be made a norm.
So, are you still not very clear, Gitanjali? So, what I could understand was that whether these risk indexes should be made a norm rather than exception.
Yes, yes, ma'am. Yes.
Okay. So, I think in a busy PAC clinic, it's probably a little difficult to go through all these scores. Most of us would not remember it also. But the basic things that we all keep asking our residents, the Mallampati, the neck movements, a general outlook of the neck circumference. And then once anything has been flagged, the neck circumference looks large, then you can probably look at these scores and go in a very structured way. But yes, it's probably very difficult to go through all these indices in a patient who, at the first look, doesn't seem to raise any red flags.
Yes. Okay, ma'am. Thank you so much, ma'am. After physical examination, after thorough history taking in physical examination, the next step is to advise investigations. So, how should investigation be rationally prescribed during PSC? What are the do's and don'ts to avoid over or under investigation while doing the anesthetic checkup? Dr. Sood, ma'am.
Thanks, Gitanjali. As we've just heard, that the ASA does not believe in any investigation. However, we in India have got a proper guideline in which we do recommend investigations. And that's because some of our patients have come for the first time for surgery. They've never had any health checkup in the past. So while we are seeing these patients in PSC, once again, history, physical examination, past history, etc. is very important. Then depending on the type of invasiveness of the surgery, we have to remember to do the investigations. So investigations should be patient specific, any comorbidity that he or she has, and the surgical invasiveness. According to that, then you decide the surgery, the investigations. Gone are the days when you should be just writing a battery of tests, starting right from hemoglobin and urine and going right in the end till echo, etc., for all patients. Some of our students still do it, but we have guidelines in our own department. And as you can see here, this is a reference from Miller, which shows exactly that which test should be ordered according to the surgery and according to the age on the organ that is involved. So it's very important that we should not just keep on ordering the things because it is a big financial burden to the hospital. Be more specific, and after having determined what is the cardiac index and other like the stop bank score, depending on that, then of course you can decide your investigations. So Gitanjali, we have to be very, very stringent and of course document everything. And you must also know when was the last investigation done. Like in our institute also, and I think in other places in ISA also, they say 3 months, if you've done the test before, then within 3 months, you don't have to repeat it. So it stands there and we have to be very, very diligent.
Thank you so much, ma'am. Thank you so much. So, after investigation, it is the time to write the prescription. So, what practical tips can improve? Before we write prescription, it is the time, it is very important that while history taking and while physical examination, what practical tips can improve patient communication and counseling during the anesthetic visit? I would request Dr. Rajiv sir to please answer this question. Dr. Rajiv sir.
There was a message from Rajiv sir that he was not able to unmute himself. Maybe that is the issue.
Is Rajiv sir not joined us?
There was a message from Rajiv sir.
Okay.
I'm not sure whether.
Sir, are you able to unmute now? Rajiv sir? Dr. Gitanjali, if you can go to the next question, we'll try to connect with Dr. Rajiv personally, and then we'll get back.
Okay, thank you so much. So after this, we must take the time to write the preoperative orders after thorough history taking, physical examination, telling patient what all investigations is required as per the case or as per the surgery. And so what are the important do's and don'ts before writing the preoperative orders? I will request Dr. Unisha ma'am to kindly address this question.
Yes, so before we start writing down our pre-op orders, one needs to confirm the readiness of the patient for any particular surgical procedure. So for that, one must review the PAC findings and the optimization status of the patient. What is the ASA physical class the patient has been allocated to, and what risk stratification patient has been given, and whether the consults of any other specialty which were asked were completed or not. Thereafter, you review the medication of the patients. That means what medication should be withheld before the day of surgery. For example, the oral hypoglycemic agents, certain antihypertensives, antiplatelets drugs, and what drugs need to be essentially continued. For example, certain antihypertensive drugs. Then, in addition to withdrawing and continuing the drugs, we need to prescribe few drugs. For example, according to the patient and according to the surgical procedure he is undergoing. For example, anxiolytics, aspiration prophylaxis, prophylaxis for thromboembolism, then IE prophylaxis, antibiotics. So that means you have to individualize this area of prescribing drugs for each patient. Thereafter, you have to write about the fasting instructions to the patient. Again, these needs to be individualized and you have to be very specific. For example, nil per orally 2 hours before surgery for clear liquids. You're allowed to have clear liquids 2 hours prior to surgery. So you have to give clear instructions regarding the fasting status of the patient. And as far as possible, we should align our fasting orders according to the ERAS protocol if the institution is, following this programs. For example, pre-operative carbohydrate loading before the anticipated surgery. Then besides this, we need to give certain anesthesia specific needs should be written as the pre-op orders. For example, if a patient has an anticipated difficult airway and I'm planning to do a fiber optic guided intubation for this patient, so then the airway equipment which is required and certain special drugs, for example, anti-sialagogue, which may not be prescribed for every patient, but here I would like to prescribe. That should be written. And suppose that patient, you are expecting an anticipated regional anesthetic, for example, then you may order for an ultrasound or a spine X-ray pre-operatively. Then any particular investigations for a particular patient and surgical procedure, for example, serum electrolytes or prothrombin time or a blood gas analysis on the day of surgery. Then a few important things also need to be written as pre-op orders. One, written informed consent as per the patient's risk stratification. Then important alerts should also be mentioned. For example, he is allergic to such and such drug, or for example, patient is HIV positive, so certain alerts for taking universal precautions should be mentioned on the case sheet in the pre-op orders. And then requirement of any blood products should be mentioned. Then also it's worthwhile to mention any special monitoring device which a particular kind of a surgery needs. For example, in a patient undergoing spine surgery, we would like to have somatosensory evoke potential. Then that should also be mentioned. So these are broadly the things which should be done before we start writing down our pre-op orders. Regarding the don'ts, especially for the fasting, pre or fasting orders. Do not write blanket orders. For example, NPO after midnight. That is not, it is not at all useful. And do not write battery of routine investigations, as Madam Sood said. Only specific investigation, if required, should be mentioned. Then do not ignore any recent symptom that the patient had developed. And when you review the PAC 48 hours before, that must be mentioned. And any particular medicine that has been started for that should also be taken into account. And very, very important, do not forget to communicate properly all these orders to your patient. If you are not communicating properly, then it is as good as not writing them, because the compliance of following of these orders will be very high, and you may land up, canceling the case on the stipulated day. So these are the few don'ts for writing the pre-op orders.
Thank you so much, ma'am, for giving the complete list of do's and don'ts for the operative orders. And that's very important. Dr. Rajiv Gupta sir is available with us. So throughout this whole PSC, the communication is very important. So my question for Dr. Rajiv sir is that what practical tips can improve patient communication and counseling during pre-anesthetic visit? Dr. Rajiv
Good
sir.
evening. Good evening, everyone. Just because my net is not working well, I have put up my video. So, a very pertinent question, Dr. Gitanjali. Because most of the time, we people feel that anesthetists work behind the curtain. So, all is because we do not interact with the patient. So this is the first window. Pre-anesthetic checkup is the first window where we can meet and greet the patient. And at the time, patient is very anxious and full of so many questions. What about surgery? Whether he'll be anesthetized or not, or what kind of anesthesia will be given to him or her, and what about pain, and what about means if something happens, will I be alive or not after that, and so many more questions are there in their mind. So to interact with them and giving solace during PAC is very, very important. And you can understand that once you talk to the patient, suppose you have done a PSC 24 or 48 hours before that, before the surgery, and when the patient comes to the pre-operative room, and if the patient finds you there, means again, the anxiety of patient is relieved. So the most important thing is to relieve the anxiety, because when patient is anxious, he needs to talk to you regarding so many things, because the surgeons are not very free and they don't have so much time, and and they feel that this is the right person to whom they can contact. So if you talk to them nicely and build trust with them, I think that is the best thing. Secondly, you need to tell them what kind of anesthesia is suitable for them and try to include themselves. If they want to suggest something like that, means you tell them which anesthesia is good for them, what is the advantage. So let the patient choose the type of anesthesia, unless unless this is there is any contraindication, involve the patient in part of the anesthesia. Then he or she may be asking about the pain. So once you explain each and everything regarding your pre-operative checkups, regarding your risks, regarding the benefits of anesthesia, which the risk benefit ratio of any kind of anesthesia, then about the pain, you can tell them that you are there during surgery, you are there after surgery. If there is pain, I am there. So you have to build the rapport with the patient so that patient feels good, and when comes for the surgery, he feels that he knows someone, because acquaintance is something which takes the patient's anxiety. So I feel these are the things which should be which are very important. Again, you can tell them regarding their fasting, medications. You can ask them about means history. History taking is something different, but communication with the patient regarding surgery and anesthesia is something which is very important. So about history and medication, all the speakers, they have very nicely elaborated. So I'll not go for that, but that is all about it.
Thank you so much, sir. Thank you so much. We all know that communication is very pertinent during the pre-anesthetic visits because we are dealing with history taking and physical examination and all that. So my next question is for Dr. Rashmi ma'am. We all know that it's an era of IRAS protocols. Rehabilitation has come up in a big way. Ma'am, please tell us how has the role of PSC evolved with the advent of modern perioperative medicine and IRAS protocols?
Thank you, Gitanjali. That's again a very important question and kind of goes into telling us that we are evolving, the anesthetists are evolving along with the evolution of the surgical fields. So IRAS, as we all know, came in the early 2000s, and it mainly means that we follow a protocol where we can ensure that the patient's duration of stay in the hospital is minimized. Now, in our country, what happens is that not a lot of patients, the kind of strata, at least that we see in our government setups, that a lot of patients may not actually fit into the IRAS, protocol itself. We may have patients who are traveling from a lot far off places. They don't have good social support. They may like to, in fact, even extend their stay in the hospital because maybe the nutrition is better, the care is better, the social support is better. So the first thing that we need to find out in our, at least in our government setup, patients is whether they are fit for a ERAS protocol or not. And like Dr. Rajiv was just describing, the pre-operative counseling, the pre-operative communication with the patient is a very major part of ERAS protocol, and the protocol starts from pre-operative counseling itself. So the one thing that we are finding out is whether we do want to give ERAS, administer ERAS protocols to these patients. Apart from that, in pre-operative period, it's a few things that is important to find out is whether the patient is a high risk for PONV, whether the patient is amenable to regional anesthesia, which can be a huge part of ERAS protocol, and what are other risk factors that may delay their discharge from the hospital. That has to be flagged in the PAC itself, and that has to be taken care of. So this is how we kind of ensure that the protocol, one, whether it is needed or not, and two, if it is needed, that we have started the protocol itself, starting from the pre-operative counseling that we give to the patients. Apart from that, the pre-operative optimization should always include something that Dr. Jayashree Sood ma'am mentioned, the exercises. Not just the physical exercise, but the respiratory exercises, the deep breathing exercises, steam inhalation if it is needed. So all the optimizations related to all systems should start if we want to institute these ERAS protocols to the patients.
Thank you so much, ma'am. Thank you, Dr. Rashmi ma'am. So this we have a case scenario. A 72-year-old woman, ASA2, is posted for laparoscopic cholecystectomy. The anesthetic checkup reveals well-controlled hypertension and diabetes. And following induction of anesthesia, she develops prolonged hypertension and delayed imaging. Now, was frailty assessment overlooked during the PSC because patients seem to be fit on paper but actually frail in reality? I would now request Dr. Jayashree Sood ma'am to tell us what is the role of newer assessment modalities such as frailty scoring, point of care testing, and perioperative ultrasound in the modern PAC.
Thanks, Gitanjali. That's a very pertinent question that you have asked. And definitely something was overlooked because, as you said, on paper, everything seemed fine, and so also on the examination. But this frailty assessment that we are talking about these days is a very important parameter which should not be missed nowadays, especially in the elderly population. because it has been seen if the frailty score is high, then definitely the chances of poor outcome is there. So frailty, when we get these patients who are above in the geriatric above age group, you have to specifically ask about the physical reserve, which we of course do ask, but we have to see the gait of the patient. Does the patient really have weakness, fatigue, weight loss, and the quality of life, how it is? So that is very, very important. And it is possible that this patient, this lady, had this and therefore she succumbed very early. As far as the newer test modalities that we're talking about, yes, point of care testing, absolutely important these days. This is because we know what we mean by this is they are done by the bedside. And most important of it, like we have the hemodynamic measurement that can be done to assess how much is the requirement of the cardiac output, the coagulation profile that we see, the TEG that we talk about, we immediately come to know what are the deficiencies in the patient, and we can immediately give the patient either the FFP or the platelets or whatever is required. And another thing that we talk about is the perioperative ultrasound that we are talking about. Yes, that of course has become so important. We know that, and you name it, and the thing can be done. Whether the patient has got difficult airway, whether he is absolutely hypovolemic, you can see what the IVC looks like. You can see the gastric, seeing the gastric emptying. You can assess whether the patient is fasting, whether it's truly fasting, and you have to take precautions of intubation. All those things become very, very important. So yes, all these modalities which are there, the frailty, the point of care, as well as the ultrasound has actually become a norm in our practice.
Thank you so much, ma'am. Now we have another case where a 4-month-old infant is posted for elective cleft lip repair, and PSC reveals feeding difficulty associated with sweating, mild tachypnea, and no prior cardiology evaluation was done. However, the oxygen saturation was normal. The surgeon requests to proceed with surgery. Now, is specialty referral particular underlying congenital cardiac anomaly is mandatory before administering anesthesia in this case? I would request Dr. Monisha ma'am to kindly answer this.
Well, Dr. Gitanjali, as you have mentioned, these symptoms like sweating, tachypnea, feeding, difficulty while feeding in a patient of cleft palate, these are all pointers towards, imminent cardiac failure or presence of congenital heart disease. So definitely in this case, I would like to have a specialty, consult. More so, we know that cleft lip palate disease entities are increasingly associated with various congenital heart diseases. And undiagnosed congenital heart diseases can, precipitate any time perioperatively, increasing the anesthetic morbidity. So, such cases we must, have a specialty consult, and because these cases have various anesthetic concerns, and according to that, the anesthetic management should be planned, and patient should be risk stratified accordingly. So, in this particular case, yes, definitely a specialty consult is, I think, mandatory.
Thank you so much, ma'am. This is another case where a healthy 25-year-old woman scheduled for daycare surgery undergoes extensive investigation during PSC. All results are essentially normal. However, surgery is delayed due to borderline abnormality. So, are routine and extensive investigations still justified in low-risk patients undergoing minor or ambulatory surgery like this? I would request Dr. Rashmi ma'am to please answer this.
Thank you, Gitanjali. Yes, it is justified. It is not justified that we get all the battery of investigations done in a patient who, by our own general physical examination and history taking, appears to be essentially normal for a minor surgery, especially if they have come for a daycare procedure. Here, I would like to mention that something called tele-PAC is being increasingly, pushed for by anesthesiologists in a big way. It will be a little difficult to emulate what Western standards are being followed for our population, for our country. Uh, but uh, but patients like these, a young woman who on general physical examination doesn't seem to be having anemia, is essentially normal, her meds are normal, she's doing her day-to-day routine work and has come for a minor surgery, a daycare surgery, we can let go of extensive investigations. Regarding tele-PAC, um, I think sooner or later some centers would try and implement it, especially where patient population is educated and conversation is easy across smart devices. We would be soon seeing tele-PAC devices and tele-PAC in these patient populations.
Thank you so much, Dr. Rashmi, ma'am. So, if we could change one thing about PSC practice today, what would it be? I would request all the panelists to kindly give one suggestion or one change that is which they feel is the the need of the hour in PSC nowadays. I would start with Dr. Rashmi, Dr. Jayashree, ma'am.
Well, what we could change, of course, a lot of things have changed. And one important thing that I want to say is that, yes, a PSC is a must. So you cannot do without a PSC. Yes, a good PSC done by a clinician who is well, an anesthesiologist who really understands the significance of a PSC. Because sometimes if PSCs are done by very junior students, it really does not carry that much weight. So this, I'm very particular that PSCs should be done by, if not a consultant, at least an SR. So that, because in some places PSCs are done by students, which is absolutely wrong. They will definitely miss something which a senior or an experienced anesthesiologist will pick up immediately. And of course, I think the other things are all covered. So it stays, of course, more on clinical basis, and lesser investigations, I think, should become the norm. That's my take.
Thank
Thanks.
you, ma'am. Dr. Monisha, ma'am.
Well, I have a very, I firmly believe that one thing I would like to change about PSC is that PSC fitness should not be treated as an NOC, no objection certificate from any authority like a transport authority or whatever, by the patient as well as by the surgeon, operating surgeon. So that the fact that it should not be treated as an NOC by the patient, for that we must make the patient aware that what is PSC all about. And that can be done. And in our hospital also, we are regularly, doing programs to make the patients aware about what is PSC actually all about. About the surgeon, they are already aware of this fact, but they don't want to practice. And how to convince them, that's $1 million question, which remains unanswered from my side at least.
Thank you so much, ma'am. Thank you. Dr. Rajiv, sir. Sir, would you suggest any one change in PSC practice which you feel like desirable?
Dr. Gitanjali, Dr. Rajiv had to leave for some another meeting.
Okay.
So
Dr. Rashmi,
we can
Dr. Rashmi
take
and
closing remark from Dr. Rashmi.
Yeah, thank you, Gitanjali. So I think one thing that our anesthesiology students should learn is what exactly do they want when they want the PAC to be reviewed. So if you're sending for a specialty review, you should exactly write that the patient has hyperglycemia despite OHAs, and please get an endocrinology referral to control blood sugar or to control, whatever is abnormal with them. Just writing endocrinology referral, just writing cardiology referral should not be the norm. And exactly what is it that you need optimization for and from which specialty is something that has to be written clearly in the PAC.
Absolutely, ma'am. Absolutely, Dr. Rashmi, ma'am. And I think if I would be asked, my suggestion would be that if same anesthesiologist can do PSC, and the same anesthesiology is posted on the day of surgery as well. Because I feel that the PSC is not only restricted to the PSC room, but it also involves the preoperative visits which are done in the ward a day prior to surgery. And we all know that preoperative anxiety is a very common cause of post-op morbidity. And the whole idea behind doing PSC, the main agenda is to allay the preoperative anxiety. This is a study which we had done in our institute where we observed that providing preoperative visits by the same anesthesiologist causes considerably lower preoperative anxiety and improved quality of recovery. So that is my suggestion. Though logistically, I don't know how much feasible it is, especially in our setup. It is not very feasible, but then this we found that can significantly reduce the preoperative anxiety. So the take-home message is that good history is the strongest investigation in the pre-anesthetic clinic. Examine what matters relevant to the surgery. Investigation should be need-based and not routine-based. We must identify, optimize, and document comorbidities before elective surgery. We should never compromise on airway assessment. Anticipation is definitely the prevention. Clear communication and informed consent are integral to patient safety. This stratification tools help convert uncertainty into structured planning. Point of care ultrasound is emerging in a big way in PSC. Tele-PSC and digital records are redefining accessibility and efficiency in preoperative care. And most importantly, the PSC is the ideal gateway to ERAS and rehabilitation, enabling early optimization of nutrition, functional capacity, comorbidities, and patient education rather than merely granting surgical fitness. Thank you so much.
Very well done.
Thank you so much.
Thank you
Thank you
so
so
much,
much.
Dr.
Thanks a lot,
Gitanjali.
Gitanjali.
Yeah, thank you, Dr. Gitanjali. Before we take up the questions which are there in the chat box, there are good number of questions which are there in the chat box, right? To our faculty panelists out here, because there are a lot of youngsters sitting amongst us. I have three things in my mind which I want you to please, for the sake of youngsters, clarify. They are very, very confused while sitting in the PAC clinic that if some hypertensive patients come to them, what is the cutoff of blood pressure on which you should be giving the fitness? And same about blood sugars if the patient is a diabetic patient. If any of my esteemed panelists would like to throw a highlight over it.
Amit, see, I think, Amit, can you hear me? See, as regard,
Yeah, very much, ma'am.
coming to the blood pressure, definitely the first blood pressure reading is not the correct one. That has to be told to them. And possibly after 5-10 minutes after you have spoken to the patient and talking to the patient, the BP does come down once you introduce yourself. And as Rajiv said, communication with the patient. So that's very important. And so also coming to the sugar, one reading is not to be taken. So you have to take subsequent readings, and that will then decide whether it is fit or not. Because nowadays the criteria for accepting patients for surgery for diabetes is also changing. So both the things, one reading is not enough. That I think we have to tell our students. And it's not
Thank you so
a
much,
joke.
ma'am. That's a good take home. Yeah.
We
That
must
don't give
not
fitness
cancel.
or don't
Yeah.
delay on the basis of one reading. That is there.
Yes.
But to Monisha madam and Rashmi madam, what is that reading for the sugars and for the blood pressure on which you should be giving fitness from the PSA clinic? Is there any cutoff?
Dr. Monisha, would you like to take this first?
I would say, I mean, 130/80 maybe, if you broadly want to say 130/80, but it depends what is the status of the patient when he's sitting in the PAC. Sometimes patients are so anxious that you can feel that the systolic hypertension 150, 160 is because of his or her anxiety. So as Madam Sood said that we would like to wait for 10 minutes, take another reading. So it's not mathematical that if it is more than 130/80 or 120/70, I will make the patient unfit. I will individualize, each patient, but grossly, maybe cutoff 130, 80. Yes.
130, 80.
Yeah, so I also agree, Amit.
Thanks.
Yeah, so I also
Yeah.
agree, Amit, that we have to individualize. A patient who's 50 years old
Yeah.
has a blood pressure of something above systolic above 130, 140, then he's probably hypertensive. But a young adult male who's say in his late 20s, early 30s, he's probably just anxious. What we do have to remember is we're not going by all these numbers. We are looking at the patient as a whole. A hypertensive patient who's already on treatment may have these blood pressures. What is important is to flag these patients. Yes, the blood pressure was on the higher side when we saw the patient in the PSC clinic, but seems like a normal ECG, seems like the patient is normal on auscultation, and could be because, maybe taken care by a robust anti-anxiety drug before surgery. So not all patients need to be referred to a cardiologist for antihypertensive therapy. It has to be individualized. And I would, my suggestion to my residents is once you keep going through so many patients, you yourself will start identifying who is an actual hypertensive patient and who needs, just some counseling and anti-anxiety drugs.
Thank you so much, Dr. Amit. Unfortunately, this second case was kept for Dr. Rajiv Gupta, sir. Sir had to leave, so we could not discuss it. But then I kept a similar case, which was case number 2. Dr. Amit,
Yeah, definitely,
if
definitely,
time
because there are a
permits,
lot of
if
youngsters.
time
There
permits,
really be
if time,
one. That is
yeah,
the
if
main
time permits,
confusion,
yeah, absolutely. If time permits, can I answer it briefly? As far as the BP measurement in PSC is concerned, the adequate rest for at least more than 5 minutes is desirable before we start taking blood pressure. The environment should be quiet, patient should be in seated position with back supported, feet on the floor. And it is important to take multiple readings, at least two, and then we average it. And it is desirable that the recheating blood pressure should be done later during the visit, rather than as a during the first contact. And it is also very important to rule out the white coat syndrome here. So if the patient has some home BP recordings, we should see that, which is important in these cases. And Dr. Amit, as far as the blood sugar question that you had asked, I feel that for elective surgeries, a blood sugar up till 180, I feel can be taken up. Uh, can be taken up. We should also keep a check on the glycosylated hemoglobin levels, which also tells us about the control in the last 3 months.
Very true.
That's all I had to add, Dr.
So there is one. Thank you so much, Dr. Gitanjali. There is one more question in the chat box that when is actually the echo indicated? Because some people do it, frantically left, right in most of the patients. So in all cesarean sections, should the patients undergo echocardiography? Any of our panelists would like to answer. This is a question in the chat box.
Amit, I had answered that question. That definitely not indicated. You can't have every lady who is not at all, unless there is some indication. It's not at all indicated. You can't.
Can I add one indication here? Nowadays, there are patients who are on chemotherapy, like patients on 5-fluorouracil, cyclophosphamide. In these patients, where we suspect them to have chemotherapy-induced cardiotoxicity. So in these patients, if they are posted for surgery, we may ask them to have a recent echocardiography.
Yeah, absolutely. I agree with that, but not that each and every lady.
Yes,
unless indicated.
Each and every, yeah. To our esteemed panelists, if supposedly the patient is having echocardiography with them report and the report is 6 months old, right? So many of our residents are very confused that is a cardiac patient. Should we re-ask the echo, repeat echo, or the same echo with hold true? Monisha ma'am, Rashmi ma'am, please.
Well, you should, there lies the importance of, again, asking good pertinent questions during your history taking, whether the patient has had any, episode of any, problem as far as his cardiac status is concerned. Was he hospitalized for that, or any treatment change was done by his cardiologist or the treating physician? I think then only, or whether if you are taking a cardiology consult, whether they are advising a repeat or a fresh echo, then only we should go, not routinely, but there are certain, specific illnesses, for example, cardiomyopathies and all. And according to the symptoms of the patient, even if it is, 2 months old, I would order for an echo, a fresh echo. Otherwise, not as a routine. It will again be tailor-made, my tailor-made approach.
I agree. So,
Okay.
what
Thank you
has
so much.
changed since the last echocardiography, and what is the information that you want to take, want to achieve? What is it that you want to achieve from getting an echocardiography done? So, someone with a valvular heart disease who's been stable for years, the last echo has been done 6 months back, does not complain of any other increase in symptoms. His meds are well preserved. I don't think we need an echo ever again. But someone who's recently started having palpitations and the echo is just 3, 4 months old, but that time the findings were not so bad. But now the patient has started complaining of breathlessness or has developed some Krebs. The examination or the history suggests that the valvular heart disease may have worsened due to some reason. Then maybe probably we need to get an echo done. What is it? What is the information that you want from that echocardiography? Is the answer where this is where the answer lies, whether you want to get it repeated or not.
Thank you so much, ma'am. What I could gather from esteemed panelists is if there is an acute onset of new symptom or there is an aggravation of the symptoms which are already there after the previous echo, we should be repeating it, but not in every case, right? There is another question by Dr. Mohan Pathak. If history is raising suspicion of malignant hyperthermia, should we ask for muscle biopsy? Anyone?
I think we will just avoid the drugs which cause malignant hyperthermia rather than get a biopsy.
Well, I don't know how long it will take and what will be
Yes,
there, but yes.
it's not a very commonly available, I mean, investigations, and it will take ages to, I mean, we will not be able to wait for the report.
Yes,
So, yes, very rightly, I agree with Dr. Rashmi also that we will just treat it that as a case of MH and plan our anesthesia accordingly.
absolutely.
Okay. Absolutely, ma'am. Right. There is another question in the chat box by Dr. Harpal which says, okay, in a diabetic patient, should we be putting the patient on insulin preoperatively in cases except minor cases? This is a very common query of most of our students also.
ਪਰ ਕਈ ਵਾਰ ਸਰਜਨ ਨਹੀਂ ਮੰਨਦਾ, ਕਹਿੰਦਾ ਨਹੀਂ ਉਦਾਂ ਹੀ ਕੁੜੀ ਦੇ ਦੇ ਉਹ ਚੱਲੀ ਜਾਂਦਾ, ਤਾਂ ਕਰਕੇ ਮੈਂ ਪੁੱਛਿਆ ਸੀ।
Very true. As Manisha ma'am has also said, that surgeon ko manana is a difficult task, right? This is particularly there. And our senior faculty members, sir's query is that surgeon is insisting that before surgery, put the patient on insulin is a diabetic patient. What would you like to comment over it?
Well, I think we should talk to the surgeon, and we should do whatever we as anesthetists feel is right for the patient. These days, many of these diabetic patients are very well controlled on combination of insulin and OHAs or whatever. So it is said that it is best to, follow whatever the regime, whatever patient was taking earlier, except for major surgeries. For example, if my patient is undergoing a Whipple's procedure or major spine surgery, long duration surgery, then definitely I would, myself like to put him on insulin rather than, OHAs, as we all know that you can control the blood sugar intraoperative and perioperatively. Better sugar control, blood sugar control can be there. But we should not do it just because of our surgeon is telling. I don't know what advantage does he gather by doing so. I don't know.
Yeah. And definitely, ma'am. We should be logical, right? Whatever we are doing, we should be logical to the patient as well as the surgeon as well. One last question, which is there in the chat box, which I want my panelists to answer is that suppose they say that blood sugars are normal, the current blood sugars are normal, patient is diabetic, but HbA1c readings are, beyond the normal range. So, what would you do? Would you go ahead with the surgery? Or would you defer the surgery?
Amit,
I don't think. Yes, ma'am, please.
Rashmi, please go ahead. नहीं, कोई आप बोलो.
So I didn't think, Amit, HbA1c is something that we are looking at. We go by the blood sugar values when we want a euglycemia in our perioperative period. So HbA1c is something that the endocrinologist uses for a long-term control for modifying or for prescribing their OHAs or insulin therapy. It's not something that is important for our perioperative euglycemia. So it's my opinion. I mean, I would like to hear about what others have to say about this also.
Ma'am, can I add? Ma'am, I think I agree with Dr. Rashmi, ma'am. Even for actually pre-operatively, HbA1c a little higher also we can take up, somewhere 7 to 8, yeah, 8.5 also can be taken, because during the perioperative period, the hypoglycemia is more detrimental. So a sugar a little higher, is not a concern. So for a patient who's scheduled for elective surgery, even if the HbA1c is 7 to 8 or 8.5, they can still be considered for elective procedure, I feel.
So certainly absolute sugar values to all students, they're more important. HbA1c is mainly for treatment modifications. Yeah, thank you very much. I think this is all about the questions in the chat box and a very nice interactive discussion. Before I hand over the stage once again to RSACP office bearers, right, I wish to thank all the speaker, Dr. Lalit Gupta, my moderator, Dr. Gitanjali Tichilkoti, and our esteemed panelists, right? Students, you are blessed to have such senior faculty members on the panel today. Right, Dr. Sood Madam has a lot of, other than clinical, lot of administrative responsibility, being a vice chairperson of a big institution. Similarly, Dr. Monisha Agarwal Madam, I know that it was very difficult for you to spare time being a dean of a prestigious medical college, Maulana Azad Medical College. There. Rajiv Gupta sir, who is an honorary secretary ISA National, every day the team ISA National has some one or the other meetings, right? And then sparing time in spite of the schedule. And we have with us me, Madam from AIMS New Delhi, high volume center for clinical cases, as well as she's in charge of set facility out there, which conducts a lot of continuous training, right? So you are really, all delegates, you're really blessed to have all the esteemed high voltage, I must say, panel today. And I'm sure you guys must be benefited through this. Thank you very much on behalf of ISA Delhi branch, RSA Delhi branch, Dr. Ahmed, and my colleague, Dr. Abhijit Kumar. I thank you once again from bottom of my heart for sparing the valuable time. I hand over back to Secretary RSA National, Dr. Vishal Singla sir, and President Dr. Naveen Malhotra sir. Thank you very much.
Thank you very much, Dr. Amit Kohli. It was indeed a wonderful session. We have with us our President, Dr. Naveen sir. Sir.
Thank you very much, Dr. Amit, for arranging such an excellent webinar. And I must thank Madam Sood, Dr. Rashmi Ramchandran, Dr. Manisha, Dr. Lalit, and Dr. Gitanjali for an excellent interaction. Thank you very much.
Thank you, sir.
Thank you very much.
Thank
Long
you
live
so much.
RSA, and
Thanks a lot for
good night,
inviting
please.
us. We
Thank you
truly
very much.
enjoyed.
Thank you.
Thank you.
Thank you,
Our pleasure.
everyone.
Our